All right, good afternoon, and thank you so much for joining us for our webinar today on motivational interviewing to improve cardiac health, practical applications. My name is Rebecca Bally. I'm a facilitation and improvement specialist with Oregon Healthcare Quality Corporation, which has been contracted by Health Insight Oregon to coordinate and facilitate these Learning in Action Network or LAN webinars. And my role today will be to moderate. First, just a brief introduction to Health Insight. Health Insight is the Quality Innovation Network Quality Improvement Organization, or QINQIO, serving Nevada, New Mexico, Utah, and Oregon There are 14 QINQIOs that bring Medicare beneficiaries, providers, and communities together in data-driven initiatives that increase patient safety, make communities healthier, better coordinate post-hospital care, and improve clinical quality. QINQIO work is grounded in principles aligning with the goals of the Centers for Medicare and Medicaid Services, or CMS, quality strategy to eliminate disparities, strengthen infrastructure and data systems, enable innovation, and foster learning organizations. Along with 13 other regional QINQIOs, Sorry about that. We had some feedback. I was just saying that the Health Insight is leading healthcare quality improvement initiatives, including the Million Hearts Initiative for the Medicare program for a 5-year period from 2014 to 2019 as guided by CMS. So this webinar is part of the Learning in Action Network efforts under the CMS project on cardiac health. So throughout this presentation, we'll be checking in with you. So I'd like to quickly review the technology that you've already seen some of it. Hopefully it doesn't all work like that. To reduce feedback noise, like we just heard, everyone will remain on a global mute throughout the presentation. We can unmute you if you'd like to talk. You just need to raise your hand, and that's a little hand icon on the right side of your screen. We do have time set aside to address your questions at the end, but we will address the questions throughout as they come through. So we welcome you to submit them anytime. You can type them in your question pane that shows right here in the little tab, and I will sort your questions and read them for our presenter to answer. Please also feel free to send me a message via this same questions pane if you have technical issues, and I will do my best to assist you. We also have a poll coming up later on that we ask you to participate in, and as always, we ask you to please complete a post-webinar survey to help us on our improvement journey. So without further ado, I would like to introduce our expert presenter today, Christopher Wells. Christopher assists clinics, hospitals, inpatient psychiatric facilities, and other healthcare organizations in quality improvement around provider process and patient outcomes for a variety of subjects, including behavioral health. He previously worked as a research associate for a nonprofit public health evaluation firm in Los Angeles. He has experience working with behavioral health providers and served as a research coordinator for a successful private neuropsychiatric practice in Los Angeles, and thus gained extensive experience in both behavioral health and holistic approaches to mental and physical health issues. Christopher received his graduate degree in public health with a focus in community health from UCLA and his undergraduate degrees from Georgia State University. So without further ado, I would like to turn things over into Christopher's capable hands.
Thank you, Rebecca, and I appreciate everybody registering for this web event today, and just wanted to briefly go over the learning objectives with you today. First off, you should come away today being able to describe motivational interviewing and how it can be incorporated into medical practice. Also explore the mechanisms behind behavior change that results from MI in relation to cardiac health. And thirdly, we're going to also discuss real stories from persons using motivational interviewing in the field. So let's start off. So what is MI? So MI is motivational interviewing is a person-centered directive method of communication for enhancing intrinsic motivation to change by exploring and resolving ambivalence. And this is done through collaboration, acceptance, compassion, evocation, and autonomy. So motivational interviewing initially started in the alcohol abuse communication as a way to empower a patient to move through the stages of changes themselves rather than being directed by a provider. And since its beginning has branched out to cover arguably every discipline you can possibly imagine. And depending on the readiness of change that your client or patient is currently in, that'll dictate the fine-tuned approach within MI that you take. Stages of change come from the trans-theoretical model, and they include the pre-contemplation, contemplation, preparation, action, and maintenance stages. Based on the familiarity of many of you, I'm not going to delve into a lot of that today, but there are resources and links at the end of this presentation that you can dive further into the trans-theoretical model. So how's this different? So the traditional provider-patient communication for unhealthy behaviors many times includes attempting to persuade by praising, cautioning, and the push for the logical righting reflex. All of this can lead to a patient reaction with silence, empty agreement, and defensiveness, which can further lead a person to feel that they're not being heard, understood, ashamed or helpless, and uncomfortable to the point of not wanting to see that provider again. This is because, with no fault of the provider, it tells them that they're the expert and that they know more about the client's health than they do themselves, rather than being a collaborative effort, and that seems to close off the kind of candid conversations that are needed to occur for a patient or client to change their negative health behaviors. And as opposed to this traditional method, motivational interviewing allows the provider to quickly gain a lot of information on the patient's situation while also showing that they're listening and attentive, thereby building the patient's trust in them. When this is done, a patient then can feel understood, safe, engaged, and comfortable to return to discuss the situation further if they're in an early stage of change. So at this point, we're going to ask you a polling question. So feel free to chime in and let us know where you think you're able to access MI training and resources, or if you know where to access them, rather.
All right, so you should see this on your screen. Just a little poll box popped up, and you can select the answer that best fits with your response. And these polls are really helpful. We polled you also in the registration, and we used that feedback. We told you to ask how familiar you are with motivational interviewing already, and we found that 13% of you were not familiar, 43 familiar, 40 somewhat familiar, and just 4% of you were very familiar. So Christopher has addressed that and adapted his presentation accordingly. All right, looks like we have everybody in. I'm going to close the poll. I'm going to share the results with you. There you go.
Okay. Excellent. Thank you, Rebecca. So it seems like about 14% of you know where, but the rest of you would either like to know more or are unaware of where to access this. So let me start by saying there's a great resource called the Motivational Interviewing Network of Trainings, or MINT. And the link is you can find at the end of the presentation. But in case you want to write it down now or browse to it, it's motivationalinterviewing.org. And there's quite a bit of useful information on MI across multiple areas of practice. There's links to videos, articles, and other resources that help you take a deeper dive if you find that this approach could aid your patients or clients. In addition, they also take a train-the-trainer approach to educating providers and have a variety of events that could be in your area soon. For instance, the next introductory course in the Portland area is going to be in April in person. They have a Los Angeles 2-day intro course the 27th and 28th of this month. I know that we have some people on the line from other states. I did look into those other states, and unfortunately I did not see anything coming up in person. However, there's quite a bit of introductory courses that you can take online that are spread across the coming months. And just as a little added bonus, you can also receive varying degrees of CME credits during this. So it's a really great opportunity. So I implore you to check out motivationalinterviewing.org. So why should we really use motivational interviewing? Here's a study, a meta-analysis by Lundahl that in 2013 showed that using motivational interviewing yielded a 55% overall increase in effectiveness over the methods compared, and that's across subject matter. And there's also greater odds of success when it's provided in a physician's office compared to other sites. So, or practitioner's office rather, instead of other sites. So, you know, this is really useful for those of you that, you know, see patients on a regular basis to know that it's really effective if you can implement this in your practice through your MAs or your nurses or, you know, even the practitioners themselves. Lundahl also found some indirect effects that are pretty exciting. So there's greater odds of eliciting patients' confidence and their intention to change, which is huge. But also it has a greater odds of eliciting their engagement in the treatment. So their interaction with you is going to be much greater if you're able to implement motivational interviewing in your communication with them, than opposed to, you know, other methods such as, you know, praising or trying to convince the patient or client that their behavior is negative. The direct effects that these study authors found was that it was over twice as likely to improve the quality of life compared to alternate methods of patient interaction, and that's across subject matter, and you know it's an overall quality of life score that was kind of given to these different studies by the authors. It also significantly influences the amount and severity of alcohol intake among the subjects of these different studies. It has a significant effect on the weight reduction and weight management of patients and clients. It also can significantly decrease sedentary behavior, increase patient self-monitoring in general. But you know, one way to look at this is, you know, from a cardiac health perspective, is you know, blood pressure, an automatic blood pressure cuff at home. You know, it might be good to implement it for those patients. So to try to get them to really stay on top of monitoring and recording their blood pressure to you as providers. But it can also increase the odds of abstaining from tobacco use, which of course in all subjects is crucial, but in cardiac health it's really essential that you're able to get your clients or patients to really hone in on that, as destructive as it can be. Furthermore, with cardiac health, you know, it has shown significant effects in controlling blood pressure and cholesterol, and that's through these direct effects of self-monitoring, decrease in sedentary behavior, and abstinence from tobacco that we just talked about. And these direct effects, coupled with resources that you can take from the Million Hearts website and other resources through there, offer your patients and clients a much greater odds of successfully completing and maintaining either an allopathic or a non-prescription based treatment regimen. So right now I'm going to give you a little example from a cohort of mine actually in Los Angeles that I used to work with that has used motivational interviewing quite a lot in his work. And while I'm reading you what he said to me, I'd like you to kind of be thinking of if you have any success stories. There were a couple people that registered for the webinar today that said that they do have some success stories that they would like to share. And as soon as I'm done going through what my cohort sent to me, I will then turn that over to you, and you can share with us. So so I'm just gonna quote him real quick. So he said, "The thing that came up for me the most when using MI is the feeling of a dance between you and the respondent when motivational interviewing is done quite well. The atmosphere is such that it doesn't feel like either is putting forth an agenda. Both the practitioner and the respondent simply explore ambiguity through conversation, and that energy feels special. It feels like a dance. I think patients having a conversation about cardiac health are going to feel threatened if one begins to prescribe them measures to change eating habits or other habits, which is what everyone prescribes to them all the time. So an MI practitioner provides the patient an opportunity to have a conversation in a way that feels different from their conversations with everyone else they've had. Albeit one of the goals of the MI practitioner is to elicit and explore change talk, the interventionist operates knowing that the respondent may simply not be ready to talk about the issue with you at that time. As with dancing, sometimes you get turned down. Good MI practice resists the writing reflex, leaves the door open, and is okay with silence. Sometimes the session is over right there. Other times you'd be surprised how being patient with somebody and giving them space really helps create the opportunity to talk with them. So thank you for sending that. It was great to hear that perspective. And as promised, now it's your turn.
Okay, so this is one of those interactive times we talked about at the beginning of the webinar, where you can raise your hand and we can unmute you, and you can feel free to share your experience with motivational interviewing, or what maybe what you've heard or seen done well, or maybe some things to avoid. And doesn't look like we have any hands raised right now, but we'll give you guys just a few moments.
And while we're waiting for that, just to go over another area that is really that uses MI that's really useful is Dr. Elizabeth D'Amico over at the Rand Corporation in Los Angeles is working on an intervention called Project Chat. And what it is, it's a brief 15-minute alcohol and other drug intervention in primary care for those that are screened at risk for substance abuse. The project was piloted with teens, families, and clinic staff in order to discover the formula for possible success. It was found that clinic staff did not believe that adolescents would talk about their AOD use or be willing to change. However, that wasn't the case at all. Teens and their families were reserved in speaking to providers not because of an unwillingness to change, but rather that they did not want to be judged by the provider. The pilot study then turned into multiple published articles and is now being actively implemented in the clinics by training providers and their staff on how to use the intervention in their daily work. Again, this example comes from work being done by Dr. D'Amico and others, who she unfortunately could not be on the line today, as she's actually in the clinic putting this to good use.
We didn't have any hands raised, but during the registration, we had some folks from Northwest Primary Care who said they had success stories to share. I'm not sure I see any of their names on the line, but is there anybody else? Oh, people are feeling shy, I think. Oh no, we've got someone here, Lindsay Tyner, who says she doesn't have a microphone but has a story to share about using MI. Used it with her 25-year-old son without him knowing, and discussed smoking cessation with him. He has now cut back from, sorry, this is actually Christina Hall, she's told me. After using motivational interviewing with her son, he's now cut back from 1 pack of cigarettes per day to 5 to 10 cigarettes, I'm assuming, not packs, per day. With his knowledge, with this knowledge, I used MI on him this past weekend, and it went great. That's so exciting.
Wow, that's great.
A very personal and real example of how this can happen, and how it doesn't have to be awkward. It can be a conversation. You know, if you do that dance right, people might not even know that you're using MI on them, right?
Yeah, no, exactly, and it really facilitates that conversation piece, rather than lecturing, that can really improve that readiness to change and action to change.
Absolutely. So thank you, Christina, for sharing that example. That was really, really wonderful. Yeah. We had another question come in about who should receive training in a clinic. I know you talked about some training resources. So is it MAs, physicians, everyone?
So, I might be a little bit biased, but so I would arguably say everyone. And Christina's example just shows that it's useful even in your day-to-day life. However, in primary care practice and any kind of practice where you're interacting with patients or clients, I really do feel like the Mint or motivationalinterviewing.org folks that do the train the trainer approach is really good, because you can send somebody out or send somebody through that training that may not be the only one in the practice that's receiving it, and then they can go and train the rest of the practice. There's not really a certificate for just being trained as much as being able to train somebody else. So you don't really need to worry about limitations in that regard. So everybody from the front desk to to the RN to the practitioner can really implement this in interaction with patients all the time.
Thank you. Mm-hmm. Keep those questions coming and don't feel shy.
Okay, moving along a little bit, and here's an area where I think it's of interest to everyone is, so how do we navigate this kind of arduous path to getting payment? So a lot of you are, see patients and beneficiaries of Medicare. So as far as Medicare Part B is concerned, it allows you to put MI to use and regular billing codes that you're already using. Take, for example, the annual wellness visit. That's a major one that you can implement MI during. Chronic care management visits. You can use CCM codes following the creation or modification of a care plan. And as many of you know, that requires 2 or more chronic conditions. And we have a link available to the CMS site on that. And then also tobacco cessation counseling, so that you can see the CPT codes on top of that. There's the 10-minute intervention, and then there's the greater than 10-minute, more intensive intervention for tobacco cessation. And both of those would be, would be great areas and interactions where you could implement MI. And then intensive annual behavioral therapy. This is a broader cardiovascular intervention, and it requires a minimum of 15 minutes. You may want to check on the CPT codes on that, because I think they recently changed. So if you need to get in touch with me and you need help navigating that, I'd be more than willing to look into that for you. I have some resources over at Health Insight that could aid you in that. And my contact information is at the end of the slideshow. Now, as far as Medicaid and private payers, you may want to reach out to, because we have quite a few different states on the line, you may want to reach out to your resources in the state for Medicaid and private payers. But also, again, you can reach out to me, and I can see what kind of resources I can get at, so that we can so that you can get paid from Medicaid and from private payers. Okay, so right now Rebecca and I are going to go through a little bit of a little bit of a practice for you. Unfortunately, due to some technical difficulties, we weren't able to get the webcam working here. So, but we are going to audibly go through a couple examples of a provider and a client or patient.
And just one thing I wanted to say is, before we go into this, is to pay attention to how long each version takes, because I think a lot of folks think that motivational interviewing is going to take so much time and there's no time in their busy practice. But I was surprised too about when we did our practice that it's basically the same amount of time.
Yeah, yeah.
So feel free to time up.
Thank you, Rebecca. And just so you're aware, these two examples are of a patient that's in the contemplative stage of behavior change, where the patient knows, in this example, that smoking is a bad habit, but may not be totally ready to take action. So, without ado. Hi, what brings you in today?
I'm here for my yearly appointment.
I see in your chart that you're an active smoker. Is that still true?
Yep.
As your clinician, I must tell you the dangers of smoking. Aside from the obvious cancers, there's also heart trouble. Doesn't your family want you to quit and be around a little while longer?
Yeah, I know about all those dangers. It's just not in the cards right now, and my family just gets on my case about smelling bad, and
Well, it does smell bad. They're right. It smells horrible. I have patients come in, and it's quite disgusting. Don't you want to quit?
I know it's a bad habit, but there are so many people that have bad habits, and I'm no spring chicken anyway. What does it matter if I quit now?
That's a pretty bad habit to have, and it's only going to make your remaining years much, much worse, including not being able to breathe. Don't you care about that?
Doctor, I'm just not ready, okay?
I see. So you're saying you just don't care right now?
Fine. I will think about it, but can we just change the subject now?
Okay. Just call my office when you're ready to talk about quitting.
Yeah, I need to find another doctor.
All right. So that was one example. I'll let you be the judge on whether or not that was the good or the bad example. Now on to the second. Hi, Rebecca. I see that you're here for your annual wellness visit. Is that correct?
Yes, and my spouse says that I need to start taking better care of my health and that I should really stop smoking.
You feel differently than your spouse about quitting?
Well, no. I know that I need to quit and that it's really bad for me, but there are just so many stressors in my life right now, and I don't really think quitting is a good idea right now.
I hear what you're saying is that while quitting is quite important, now is not a good time because of too many factors that make it difficult. It's up to you when to decide to make any lifestyle or behavior changes. But for you, what's the drawback from not smoking anymore?
Yeah, well, I'm afraid that I will be, really stressed out and yell and be mean.
I understand that you're afraid of being mean to people close to you, and that's one thing that's holding you back from deciding to fully quit.
Exactly. But I know that probably doesn't make any sense because my family loves me and would probably put up with me.
I hear you saying you have a strong support system. That's great. For you, what would be a benefit of not smoking?
Oh, well, geez. I could probably breathe better, smell better, maybe live longer, definitely save some money.
It seems as though your benefits outweigh the drawbacks to not smoking. Deciding to quit is a decision that is completely up to you, and I heard that you're not ready to make that decision right now. Would you be willing to further think about this and follow up with me in about a month to discuss your thoughts at that time?
Sure. Thank you, doctor. I'll schedule an appointment with your office out front.
You're welcome, Rebecca, and please remember that the next step may simply be preparation for action, and that's okay. So again, that was the Oscar-worthy performance from Rebecca and myself. So if you have any thoughts or questions from that, please chime in. You can either raise your hand or go in the chat box.
Yeah, just tell us sort of what you thought. How did that feel? Did it feel realistic? Obviously, it was definitely a little Hollywoodized, but as much as we could do. But does that resonate with how conversations might happen in your practice? Or tell us what you think. Somebody asked, did you purposely not use a readiness ruler?
That was not purposeful. Again, the readiness ruler is due to the familiarity of a lot of people. I didn't really delve into that, and I was trying to make it brief, a little more brief, so that we could get more interaction from you guys out there, so that we could hear about some success stories and other experiences with MI.
Yeah, thank you for that question. And I'm sure we can, some of the resources that Christopher mentioned, can go into deeper depth about that. Any other thoughts before we move on? Second conversation felt balanced. Both the patient and provider had power. I love that you said that, Susan, because it really is supposed to be a partnership, right?
Yeah, it's like that dance that we talked about earlier. You know, it's that to and fro, but it should feel really natural. So the natural base may not have come out as much in our acting skills, but you know, it's really going to feel a lot more natural and like that dance.
Thank you guys for sending in comments. These are great. We also someone said, I like the use of I hear you and I understand your problems. Makes the patient feel understood instead of attacked.
Yeah, and that's really what it's about. Is reframe. We're going to go into this a little bit in the next slide, but it's really about reframing as opposed to, and restating as opposed to asking questions. Because when you ask questions, a lot of times what can happen is there's somewhat of a wall put up, and they can become defensive and you know, have a negative reaction.
Especially if you say, do you understand? And they go, uh-huh, yeah. So Amy shared with us, she's an RN educator at an inpatient unit at OHSU on cardiac floor, where we're teaching our patients behavioral and lifestyle changes to manage their heart failure. Our patients are very frustrated with having to make these changes, and a lot of them will shut down our education sessions by saying, I already know everything about this disease. I've been living with it for years. How can we work with this from patients? Any suggestions?
Yeah, so one thing that's really good about MI is that, you know, that flow of the conversation starts at their readiness to change. So if they're not ready to change at all, what you can do is open the door for further conversation. But in order to get them to start thinking about that change, if they're not at that stage yet, you can really kind of not give them black or white questions or talk about information that can be black or white. So, you know, you say, you know, on a scale of 1 to 10, how, you know, and this is that readiness change scale, you know, on a scale of 1 to 10, you know, how bad or how negatively does this affect you? And they, you know, they say, oh, it's a 3. You say, okay, well, what would make it a 1? Or if it's a 3, you know, what does an 8 look like? You know, and that really allows them to explore the possibilities that you know, that's around that. If they, you know, if they say, oh, it's a 0, it doesn't negatively affect my life at all, you can say, oh, okay, well, you know, ask them, you know, what does a 1 look like? What does a 10 look like? You know, and have them figure out that balance themselves. And they may not come around right then. You know, I know what we're discussing here is kind of in a perfect world, and that doesn't really happen a lot of times when you're interacting with patients or clients, especially around behavior change. But what it does do is it elicits that and it evokes that self-confidence in themselves that they know where they're at, and when they know where they're at, they know where they can go.
Mm-hmm. One of the other things about Amy's question is she said, you know, patients are frustrated and they're shutting down the education sessions, which makes me think that, you know, this conversation that we just did isn't necessarily happening outside of those sessions. And I'm wondering if you have thoughts about whether or not there is some training that needs to happen to have that conversation at a different place. So before you even ask them to join the education session, is there some motivational interviewing that happens?
Yeah. Yeah, so, excuse me, that's why I was talking about implementing or employing this method, from greeting the patient to, booking the follow-up appointment. Because, when you use this in the daily interactions with the patients at every single step, by the third step, when they get to that provider, or when they get to that education provider, they could be more willing to listen if they've already encountered, one or two people that are having that type of conversation.
And just a final thought on that. We have a couple other questions, but we heard in other webinars too, people sharing examples that trying to make it relevant to them.
Mm-hmm.
I mean, maybe they're not interested in hearing about eating healthier, exercising, but they might be interested in hearing about how they can spend more time with their kids, or make it to their grandkids' high school graduation or something. And so making it relevant to the patient, and I think is an important factor. We have another question about, it's kind of related actually, from Natalia about, as a provider, how much do you want to push against resistance when you encounter it? So somebody's saying, I know I'm not ready. Do you push that, or how do you address it?
Yeah, you don't really want to push too much, if at all, because that really elicits a negative response. It really backs somebody into a corner. I mean, you can kind of imagine, like, even in a daily interaction, if your spouse or significant other is kind of pushing you to make a decision, you kind of feel like you're backed into a corner a little bit, and you're on the defensive, and that's not a good stance for behavior change in any respect, really. So, in implementing this, kind of think about how it would feel on the opposite end. If you were encountering somebody that was kind of using that type of thing, how would it make you feel? How would you respond to that sort of situation, and then go forth with that?
All really great suggestions. Thank you. Somebody asked, Janice asked, will this webinar be available to listen or see again later for those who missed it? Yes, we are recording. I forgot to say that in the beginning. We're recording this webinar. We will post the slides and the recording on the Health Insight website and the peacetci.org website. So thank you for asking that. Another question. It seems like most of these are related to tobacco cessation. Is there an example of a situation for using MI to improve cardiac health not related to smoking and tobacco? Yes.
Yeah, no, there definitely is quite a few examples of implementing this in cardiac health other than tobacco cessation.
And really, you could use it for anything, right?
Yeah, blood pressure control, blood pressure control, cholesterol control. Like we were talking about, the self-monitoring aspect. You can use it as a way to discuss them taking their own blood pressure. And something that's cool that's going on right now is there's actually grants out there that could help you fund blood pressure cuff purchasing for your patients, and then that takes away an additional barrier to quite a few patients is the cost, and that takes away the cost aspect, and then you can just focus on the implementation part of it. All right.
Those are all our questions for now. I'm sure we'll get more as we continue on. Thank you so much for interacting with us, everyone.
Yeah, thank you. That was a great interaction. So next, some potential barriers, and we already covered quite a few of these actually in our interaction just now with your questions. So I definitely appreciate that. So a little more natural that way. So time and training is one. So the time that it takes, as discussed earlier, can sometimes feel like it can take quite a while to implement this in your interactions with the patients, and that's just, as you've seen from our example and from research in the field, it's just not the case. You can implement this in as short of an amount of time as possible. Rebecca and I worked on that, and it was under 3 minutes that we did both examples. So that, and then going into training, like we talked about, there's quite a few resources out there. Motivationalinterviewing.org or Mint, they have quite a few links to Vimeo videos. There's also quite a few videos on YouTube surrounding motivational interviewing for a variety of subjects. And there's also, through Mint, there's those online introductory courses, which are great. I think they're slightly under a month long, and I think they meet once or twice a week online, and then there's also, I think, a phone conversation that occurs during some of that. And again, it's CME. A lot of them have CME credits attached to them, so that's a great benefit to providers out there looking to increase that. Next, asking questions. Really asking. That's, many of you might be thinking that's how I get information. But as you just saw, and as we discussed from one of the questions, that's actually not the only way to gain information from your client or from your patients. And it sounds counterintuitive, but reflecting the statement back instead of asking questions offers the patient the opportunity to correct and expand rather than simply replying with a short response. And even if and there's kind of this thing, at least in my head when I first started hearing about this, is like, well, what if I restate it incorrectly? Well, that's okay, because it gives them the opportunity to say, well, no, that's not entirely accurate. It's actually this reason, and it kind of gets the wheel turning in their minds a little bit about maybe moving on to that next stage of change if they're at a lower one. Moralizing, cautioning, and judging. I mean, this is all. We all know that adding morality and judgment to change is not really an effective way of eliciting the behavior change. But as a health provider, you need to really try to steer away from the cautioning aspect of interacting with your patient. So, for instance, if your patient has high blood pressure or for instance has bad cholesterol, cautioning them that their regular trips to McDonald's is not a healthy way to live. It may work with some, but then with others it may not work. It may be that that's something that they've routinely done for many years. So telling them that it's bad for you, it's not news to them. They can watch the Today Show in the morning, and Matt Lauer tells them not to eat fast food, but so what? You're no different. And then self-doubt and their skills. I mean, this comes through self-doubt and skills as providers. This comes from from the training that you can receive, and also from regular practice, putting this to work. You don't have to go through one of these trainings necessarily to kind of practice this. When I first learned about motivational interviewing, I tried it out with my significant other. You may want to tell them that you're doing it at first, or else it might elicit a negative reaction. They find out, but I'll leave that up to you. And then lastly, the doubt in the patient's ability, their finances. Implementing these techniques can really raise the level of importance for the problem behavior that they have, which then in turn can surpass those potential barriers, such as finances. I know that in this day and age there's a lot of people, a lot of patients that are in poverty. But a lot of the behavior change that you can elicit from MI, it doesn't cost anything to them, and a lot of times it can actually save them money. So that's definitely an approach. And you're a team. It's like we talked about before. It's not just the provider. It's not just the RN. It's the collaborative effort with the patient. And like I said, not everybody may succeed from this type of intervention. However, if you want to do well, just remember I put together a little acronym, and it's ACE. You can ACE the test. Assess the patient level of change. That's excuse me, that's the citation that you'll see at the end that talks about the readiness of change in the trans-theoretical model. You know, the communication that we've talked about this whole time, and then explore, engage, and empower. You know, that from that communication, it allows that exploration, that natural exploration. You know, it allows the patient to feel like they can engage with you and comfortable doing so. And then, you know, further, it really empowers them to really be able to make that change and to know that, you know, they have you in their corner, they have you on their side, and that you're not, you know, you're not the, you know, the on the pulpit just trying to tell them, you know, you have to do this or else, you know, it's going to be bad. So, so really, it's what it boils down to is it's really a collaboration between you and your client or patient. So whatever level you choose to implement this at, whether it's at the provider level alone or the clinical level, you know, it really can be beneficial to anybody that tries it. So, you know, give it a try. If it doesn't work, it doesn't work, but at least you gave it a shot.
Okay, so here's some resources.
Yeah, here's some resources we discussed. MINT, like I said, the Motivational Interviewing Network of Trainers, that's their link. There's also a link to a brief intervention guide for substance use and implementing that in primary care that comes from RAND. And it says brief, and it is brief, but it's also quite in-depth. So it's really educational for you to be able to go through this PDF. There's also tools available at the site there. You can see different manuals for different aspects of MI. Chronic care management, which we talked about, there's a CMS link there that will provide more information for those providers that have Medicare patients. Preventative care CPT coding, again, this is kind of, you know, it's kind of a gray area a lot of times, you know, kind of confusing and convoluted, but there's an area there from CMS's website that you can find more information, as well as tobacco cessation coding. And again, for any of these resources, if you don't have time to go to it, or if they're not in depth enough or you didn't get the information you needed, please reach out to me to my email address that you'll see at the end of this slideshow, and I'd be more than happy. If I don't have the answer, I'm going to find the answer for you. So those are some resources, and further some of the references that we cited here. So.
Okay, and I also put in the chat a link to our behavioral health resource, or behavioral health integration resource library on the PCCI website, which has some of these resources and others. But now is again your chance to ask us questions the same way that you've been interacting already through the question pane, and we'll read them and answer them as they come in. One of the things I wanted to say is you'll notice this wasn't an MI training, right? This was a very high level on what is MI, and then sort of how do you make sense of it for a very practical reason, like bringing it into your practice, just to show you that it can be very simply done. It is can be a complex model when you get into all the weeds of it, and that's why there are day-long trainings that people go to, multiple days. Yeah. So that's why we didn't do that here. We just wanted to give a more of a high-level practical approach to it. So one question to sort of kick us off as folks are thinking about other questions that they might have is, what next? So folks have been on this webinar. They've they've heard what you've had to say. They've heard some of the questions come in. What are the next 3 things that they should do?
Yeah. Well, first off, you should definitely think about whether or not it would be practical or useful in your practice. And if it does sound like something that would be useful and practical to you, then checking out these resources is a big next step, especially the MINT resource, motivationalinterviewing.org. So that's going to be a great resource for finding finding training materials. Again, YouTube videos and Vimeo videos are really helpful for seeing that interaction on multiple, across multiple subjects, and also good and bad interactions. I've seen quite a few of them, and while they can be kind of dry, there's definitely some useful material out of there. And then also, especially if you have a larger practice, really taking advantage of that of the Mint, either online resource, online training, or if it's coming to you locally, one of the local trainings. And the trainings are not done directly. Most of them are not done directly from the organization Mint. They're done through the network of trainers. So people that have been trained to train others put on these events. So not only are you going to learn the nuts and bolts further and delve in further than we did during this webinar, but you're also going to really get the feel from somebody that's in the field, which is something that's really great. And so and then the third step after that is either exploring it with your cohorts in your office, or your staff in your office if you have a larger practice, or just piloting it out. I mean, this started from research, and it's in practice right now. It's being implemented, like I said, from Dr. D'Amico, who has written quite a lot on the use of this across with adolescents and Native Americans, and for substance abuse and juveniles. And she's in the clinic right now as we speak, training people on how to work this into a 15-minute intervention. So that's really what I would suggest.
Thank you. We have one quick question and then a longer question. So the quick question is, are these Vimeo videos that you mentioned listed in the link?
They will be available on motivationalinterviewing.org. So you can go there. I believe they might have the YouTube videos as well. If they don't have the YouTube videos available, you can just go to youtube.com and type in motivational interviewing. You'll find quite a few videos.
Perfect. And are those videos of people practicing, or you can see?
Yes.
Okay.
Yes.
Thank you. And then the longer question is about, and you touched on this sort of at the end of your last answer, about how do you get this into a 15-minute visit, right? I mean, I think if people didn't see already that it can be really short based on the example that we gave, where does it make sense? Where does it fit when those 15-minute visits are already like jam-packed with a lot of other things that you've got to get done? You're checking that off the list.
Well, I mean, it can fit in just in the regular conversation within that, 8, 12, 15-minute interaction. It really doesn't matter the subject matter about this. It doesn't have to be with cardiac health or tobacco cessation or blood pressure control or alcohol abuse. It can really be about anything with the patient. Like the second example that Rebecca and I did, a lot of times that's not going to happen where, the patient right off the bat says, yeah, I'm here for my annual wellness visit, plus my wife thinks I should quit smoking. No, that may not occur, but through this, and I hark back to this, through this dance, you're able to really get that information out rather quickly. And, and one thing to keep in mind is when the patient walks in the door, they may already, be on the defense because they don't want to be there. So by restating rather than, cautioning or asking clarifying questions, but rather restating what they've said, whether it's a short sentence or, a longer paragraph that they stated, it gives them the opportunity to really adjust what you said. So, and it will allow them to delve deeper in a more quicker way.
Perfect. Thank you. I think that's great, and I think that's probably what a lot of people are thinking.
Mm-hmm.
So we have just about 5 minutes left here. I think we've covered a lot of questions, and if you're I'll give you a chance to give some just final parting thoughts, and then I'd like to give the audience, thank you so much for joining us today. I'd like to give you guys a few minutes in the hour to fill out your post-evaluation survey. So final thoughts, things to think about.
Yeah, so I'll put my contact information on there. Again, the slides will be available to you following the webinar here, but in case you want to write it down real quick, this is my direct line, direct phone number, and direct email address. However, motivational interviewing is really a good, it's really a good interactive communication across the landscape, you know, even, like I said, even in our day-to-day interactions with people, you know, you can add this to, you know, kind of the, you know, positive psychology even. You can couple it with that. You know, the nice thing about motivational interviewing is, you know, it's not necessarily you have to do it this way. You know, you can bring it into your practice at the level that, you know, you're ready to implement it. And, you know, it's not going to be, it's not going to be hurting your practice at all. You know, if you implement it in a little bit, partially, fine, get comfortable with it, try it out. You know, if you don't like it or if you have further questions, you know, get in touch with me, get in touch with the folks at motivationalinterviewing.org, and, you know, there's really a great resource on that website that people from all over the country and actually all over the world that are using this, and they can really steer you in a good direction, and I will as well. So here's my contact information, and I appreciate all of you logging on today. It was very exciting, and I'm glad that there was so many questions and comments. That's great.
Yeah. Perfect. Thank you so much, Christopher. I really appreciate you bringing your expertise and guiding us through this conversation. I think it was a really good one. And thank you, everyone on the line who joined us for an hour in the middle of your afternoon. We appreciate you being engaged and asking lots of questions. So again, like, feel free to contact us for further questions. The next webinar in this LAN series will be on Tuesday, February 21st. And on that one, we are going to be talking about the phase 2, essentially, of Million Hearts. So as phase 1 is winding down from the end of 2016, we'll be talking about what's next. And please do complete your post-webinar survey. That helps us to know if we are doing a good job, if we are giving you the topics that are interesting to you, if we're delivering them in a way that's helpful for you. We really take that feedback seriously. So I'll give you the next 3 minutes to fill out your surveys. And thank you so much. Have a great rest of your day.